All right, so we're going to take a moment to discuss the catecholamine dump or sympathetic dump of our patients. But before we go into it, not only have I snuck the word dump in multiple times, but let's all appreciate the greatest title slide of all time, which is, in fact, a catecholamine taking a dump. So I'm going to start off with a scenario. So we imagine we get dispatched to a interfacility transfer. We show up and we have a critical patient that we have to transfer, say, 30, 40 minutes. You walk up, you get your story from the nurse. We'll say it's a septic patient, and they're on multiple pressures. We'll say epinephrine and norepi both at moderate to high dosing. And you glance over the monitor and you see the vital signs as you see there. So we've got a BP of 104/60 and a heart rate of 142. And so the question that I want you to ask yourself is would you feel comfortable discontinuing those pumps, turning them off, disconnecting from the patient, and moving them out to your ambulance and just kind of seeing where things go. Try to take your transport without having those on. And hopefully, as soon as I suggest that to you, your thought is absolutely not, because we understand that although we have a normal to appropriate blood pressure for the patient, that blood pressure is sustained by the dual infusion of those two catecholamines. And so if you were to turn them off, you're going to end up with a patient who's going to be quite hypotensive and perhaps arrest on you. So in the second scenario, we have a sick patient in the field, same vital signs, it requires procedural sedation. And so the question I would say is you're staring at your monitor, you see a blood pressure of 104/60 again, heart rate of 142. Do you feel comfortable providing procedural sedation? Don't concern so much about which type of procedural sedation. You can pick whichever one you like, ketamine, etomidate, propofol. Would you feel comfortable deeply sedating the patient? And the answer to that hopefully is absolutely not, because when we apply procedural sedatives to the patient, we kind of do similar to what happens in that first scenario where you turn the pumps off. So uh, if you get out in the field or any healthcare situation where you have a patient with those kinds of vital signs who presents ill and has some underlying disease or suspicion of underlying disease, whether trauma or medical, it really doesn't matter. The vital signs that you see when you see that heart rate of 142 and you see a blood pressure of 104/60, that is generated by the patient's internal epinephrine and norepinephrine pumps. Right? Those pumps are located just above the kidneys in the adrenal glands, and although you can't see them actively infusing into the patient like you do in scenario one, they are there. And when you deeply sedate a patient, even with hemodynamically stable sedatives, you turn those off, or at least dramatically turn those down. And so patients who are in a compensatory shock transition to decompensation, or a decompensated shock, and or can potentially arrest. So one of the riskier things that we do in emergency medicine is provide procedural sedation to this patient population. That is a high risk um, procedure, and it should, and I'm not saying we don't do it, but we should do it with a lot of care and caution. So as much as I talk about ketamine all the time, even ketamine is a potential culprit. In fact, I would argue, especially in EMS, ketamine ends up being the biggest culprit, because we tend to, when we're taught about ketamine, we understand that it's not just hemodynamically flat, but even perhaps slightly pro-hemodynamic from a pharmacologic standpoint, since it's a catecholamine reuptake inhibitor. And so we're all taught initially that if you were to just give ketamine to a patient, they might actually have a slight increase in blood pressure and heart rate, which is true if you give it to a hemodynamically stable, healthy patient. If you just dissociate a patient on ketamine for a procedure and they're completely rock solid stable, you probably would see a small increase in blood pressure and heart rate. But in the critically ill patient, in the compensatory shock patient, that small bump that you might get from the pharmacology of ketamine is outweighed by the loss of sympathetic response that's associated with deep sedation. Now, this is exaggerated in sedatives that have a vasodilatory response or a hypotensive side effect, such as propofol or Versed, especially are big culprits, because not only are you getting that sympathetic dump, but on top of that, you're causing some peripheral vasodilation as a side effect of the sedative. But regardless, irrespective of the sedative choice we pick, if you achieve deep sedation, you are risking decompensation in the patient with compensated or decompensated shock. Okay, so a little bit more on the pharmacology of ketamine because it's quite different than the classic sedatives we use. So your propofol, your etomidate, your Versed, your benzodiazepine types drugs, even phenobarbital and some of the lesser common sedatives, the vast majority of them are GABA agonistic drugs, and so they're just true central nervous system depressants. And the more you give, the more you kind of get a lot of everything with them. And so as you dose up with them, inevitably, if you get to the higher doses, and especially once you reach procedural sedation, you end up with not only some vasodilatory effects like you see with Versed or propofol especially, but you also start seeing more risk of respiratory depression and apnea, which is not ideal in essentially any setting, but certainly not in the chaotic environment and uncontrolled environment of the pre-hospital and emergency medicine world. So ketamine's kind of unique in that it targets different receptors. So it's an NMDA receptor antagonist, and kind of a very basic way of how it works is it prevents the brain from processing outside signals. And so at low doses, you get true pure analgesia without the use of opioids. And then as you kind of dose up, you start passing through the recreational and partial dissociation world, which really has no use or minimal use in our world. And then eventually, somewhere around 1 to 2 milligrams per kilogram, you get that full dissociation. And it's at the full dissociation that you're at the greatest risk of turning off those internal epi and norepi pumps. And so you want to make sure that when you're making that decision, when you have a critically ill patient and you're choosing to dissociate them, kind of irrespective of the cause of their shock state, you want to make sure that A, you really need to do that, and B, that you prepare and try to compensate for that. So I'm certainly not saying that we don't. In fact, we dissociate lots of critically ill patients, but this is a big risk factor, and so we want to make sure that when we're choosing to do this, that we're preparing our patient appropriately. If you're using lower doses, like in the pain control world, so 0.1 to 0.2 milligrams per kilogram IV, you're much less likely to get that sympathetic dump. So that's a pretty safe non-opioid type pain management. But it's certainly a decision that we want to make prior to committing is, do I need that full dissociation? If we're taking their airway, of course the answer is yes. But in other cases, like perhaps like pacing, we might make more of a decision about, do I really want to take out their entire sympathetic response versus try just some pain control dosing first, because especially in the world of like cardiogenic shock and symptomatic bradycardia, they often have underlying illnesses that they are going to have to, that they will be enduring for some time until they get definitive care. And so if we can manage those with less invasive, smaller doses, then that would be ideal. But certainly if it's an airway case, you're going to have to dose up. And so we want to prepare, because once we hit that 1 milligram threshold and we hit dissociation, we're going to be turning off that patient's internal epi and norepi pumps, and they're going to crash on us. And so we want to supplement that loss of endogenous sympathetic tone, that loss of endogenous catecholamines, with exogenous catecholamines via intravenous either push dose epi, push dose norepi, plus or minus starting infusions of those medications, ideally prior to the administration if possible, so that we can adequately prepare. In the airway case, the goal, truly any dissociation case, the goal should be the prevention of hypotension. And I do feel like sometimes we tend to be reactive instead of proactive in this case. And so we really should look at it as a fail anytime we're handling, especially an airway case or a case in the emergency world where we are providing procedural sedation and they develop hypotension. You shouldn't save the vasoactive agents for after hypotension ensues. You should predict the hypotension and be proactive and preemptive in your administration of the vasoactive agents so that they don't drop below, because even transient drops in blood pressure below critical thresholds can reduce coronary perfusion pressure, plus or minus cerebral perfusion pressure, which can cause neurologic or cardiac injury and perhaps arrest. All right, so how are we going to predict the person who's going to decompensate when I give the sedative? So there's a couple of approaches. The evidence-based approach is to use this thing called shock index. So that's looking at the patient's heart rate and systolic blood pressure. In fact, you divide their heart rate by the systolic blood pressure. If it's greater than 1, that's a patient that you're going to need to resuscitate prior to sedation. And if you think about it, all the shock index is really telling you, especially if my heart rate is greater than my systolic blood pressure, is that that patient has a intact stress response, that their endogenous catecholamines are increased, and when you provide sedation, they're going to turn off, they're going to go down. Because as any patient's epinephrine and norepinephrine start circulating, their heart rate's going to go up, and inevitably it's going to transition above their systolic blood pressure. It's a good example of we got to get away from looking at just that systolic blood pressure greater than 90. I have multiple cases where the patient's blood pressure starts out at 120, 130 systolic, and then by the time it's all said and done, even with the administration of vasoactives, we're fighting to keep it above 90 systolic and fighting to keep above a MAP of 65. And so I can't stress enough that the deep sedation is a difficult thing for management. And depending on the shock state, and especially if you're intubating the patient, the the co the duality of administering a sedative along with transitioning from negative to positive pressure ventilation, those two things together, that kind of 1-2 punch combo, can be hugely impactful on their hemodynamics. Like all medical tests, it's not perfect. In fact, there's a lot of studies, if you do some Googling, will show you a shock index of 0.8 or greater. Um, they're both completely accurate, whether you use 0.8 or 1. It kind of changes the sensitivity and specificity depending on which one you pick. The reason I teach everybody 1 is just because it's very easy to do in the back of an ambulance or in the middle of resuscitation, because you're not actually doing any math to figure out if it's 1. You're just looking at it and going, is their heart rate greater than systolic blood pressure? If the heart rate's higher, it's going to come out greater than 1. If it's greater than 1.4, that's actually a big predictor of mortality, especially in like septic patients. So it's a huge warning sign. And especially in the EMS world, we tend to be very reactive with our vasoactive agents. And so what this number means is that you should be resuscitating ahead of time. We should take it as a fail if we go to sedate a patient and they become hypotensive. We should not wait until they become hypotensive to react. And this hypotension is associated with the loss of catecholamines, and so this is something that we should be preparing catecholamines. There's essentially no airway case where I don't have vasoactive agents drawn up and ready. I'm not saying you can't give fluids, especially if they're indicated, but this is a patient where the cause of hypotension is a drop in norepinephrine and epi, and so you're going to be correcting that inevitably with norepi and epi. You can always, after you get them sedated, plus or minus get them intubated, and things kind of calm down, you can always reassess where you're at with your dosing and decide, do I need that? Can I get rid of it? This is where a lot of people rely on push dose norepi and epi as well, to try to bridge them through this process. But this should be prepared. If your patient has a high shock index, this should be prepared. And in all honesty, almost every airway case, no matter what it is, I'm preparing it as part of my just plan, because this is a very common thing. And if you look at the evidence, the number one cause of mortality in airway cases was not that we sucked at intubation or couldn't figure it out, or did something stupid from a skill standpoint. It's because we failed to recognize this, because the number one predictor was not those things. It was shock, and or on vasoactive agents prior to sedation. Another just common sense scoring system I like is the do they look like shit? I think that resonates with every emergency provider. It's inherently built into us. You didn't have to go to school to learn to look at somebody and go, do they look like shit or not? If they look like shit, that tells you that the patient has an unchecked stress response, and that is the thing that we want to not lose. And if they are sympathetic reliant, we don't want to turn that down. So a little review on kind of our two major players. So you'll see some agencies and some providers talk about the use of agents aside from norepi and epi. So I've heard lots of people, especially in airway, talking about neosynephrine. That really makes no sense. Neosynephrine comes from the anesthesia world where they're using vasodilatory agents, and they're using the neosynephrine to offset that. So if you look pharmacologically at how neo works, neo is a pure vasoconstrictor. It's a alpha-1 agonist, so it causes peripheral vasoconstriction. in these patients, the hypotension is not associated with vasodilation. Specifically, it's that loss of norepi and epi, so we should be supplementing with those. Plus, in the emergency world, we don't, neo is kind of a niche drug for specific things, and we often are dealing with a multitude of things. We often don't have a lot of info to determine shock states, and so neo is not going to provide any cardiac support. And so if your patient has any underlying cardiac issues that are associated with their shock state, neo in essence could potentially make it worse. And it's going to fool you because their blood pressure would still go up with the neosynephrine, because blood pressure isn't a direct marker of perfusion. And so if you squeeze down on the vessels enough, you're going to get a blood pressure. That doesn't necessarily mean you made them better. So it can actually fool you because you can sit there and go, oh, well, their blood pressure went up, but you didn't actually improve the patient's tissue perfusion and oxygenation. So I don't think that neo has any place in the airway world for that emergence airway. We should be relying almost solely on norepi and epinephrine in those cases. So more on the two catecholamines we're going to be using. Norepi, it's the ideal agent in essentially almost every shock state. If you look at the evidence, it's certainly the superior agent in sepsis. They just published a study on it being the superior agent in post-cardiac arrest hypotension. It's essentially every patient, minus a few, it's going to be the go-to. And even in the ones where it's not quote-unquote the ideal agent, it would still work very well. It's an alpha and beta agonist, so you get some vasoconstriction and some cardiac contractility. It does tend to be a little bit more heavy on the vasoconstriction compared to the beta effects, but again, a very good drug. If you use 4 milligrams in 250, that is also a push dosable concentration. So every milliliter would come out to 16 mics, which falls right in line with a pretty high to normal dose of norepinephrine from a drip standpoint, which most people are using somewhere in the vicinity of 2 to 20 mics per minute, if you're not using a weight-based system. But regardless, a 16 mic push in an adult patient is a pretty safe and advantageous dose if you're going to push dose it. I really like it because, especially doing it from a mix standpoint, I know a lot of EMS providers have adopted the push dose epi, and they're mixing up the code epi, and that's totally fine. And if that's all you have, I'm not knocking it. But it's extra steps, and when you mix up push dose epi, that's all you have is push dose epi. And a lot of these patients are going to end up on an infusion or require an infusion. And so if you do norepi, not only are you mixing up a good push dosable drug, but you're mixing it up while making up the infusion. So you can you mix up the bag, you draw some up, you hand it off to your partner, you can start push dosing norepi while your partner is setting it up on the pump. And if you end up deciding you don't need the push dose, you still have the infusion set up and ready. So it's just a very nice, easy, clean way to go about it. And since it has less beta agonistic effects, you're less likely to see some of the arrhythmias, tachyarrhythmias that can manifest when you give epinephrine in certain cases. From a disadvantage standpoint, it's not the greatest for bradycardia, and EMS providers especially are not as comfortable with it, so they tend to kind of be more conservative with it, even though it really is kind of the safer of our vasoactive agents. At lower doses, norepi really just causes venoconstriction versus arterial, and so you're going to get some preload without really worrying about taxing the heart too much. It can actually help augment any fluid boluses that you'd be giving, especially in cases of like profound vasoplegia where you might be dumping fluids in, but it's not really, there's no conduit for the fluid to travel. Norepi is going to provide that vascular tone and help augment that fluid. So epinephrine, tried and true, some huge advantages of this. EMS providers are super comfortable with it. It's on every ambulance and ED crash cart essentially on the planet. At the right dose, it's good with severe bradycardia, so that normal range is around 2 to 20 mics per minute, and so anything less than 10 per minute is kind of where you get that really good beta effects. If you start increasing it beyond that, you end up with more alpha effects. But if cardiogenic shock and bradycardia are the things you're attacking, then that 2.5 to 10 mic per minute range is ideal for that. It also provides you bronchodilatory effects, so if bronchospastic disease is part of what you're dealing with, you're not only going to help with the hypotension, but you can help to improve the respiratory problems associated with the patient. And then, of course, if it's anaphylaxis, it's the gold standard drug. So those are some of the advantages to it. Some disadvantages, depending on the agency, your push dose mix might not come out the same as your infusion mix, in which case if you mix up push dose, and especially if you do the classic mixing up push dose using intravenous code epi, they're the 1 in 10,000, then you have to do 2 mixes because you have the push dose and then you have the drip. Again, it's not the end of the world, and if you're in a resource-heavy environment, it's certainly not a big deal, but that is one disadvantage compared to norepi. And the more beta adrenergic effects can increase the risk of arrhythmias. So, if they're tachycardic because they're compensating for a shock and you give them epi, probably not going to affect the heart rate a whole bunch, but it can cause them to go into like SVT or A-flutter or AFib with RVR. And from an evidentiary standpoint, it is proven inferior to norepi in post-arrest sepsis and a couple other common shock states. Now, I talked a lot about the 2 primary vasoactive agents, but let's not forget there are other types of shock. So if we have a bleeding trauma patient and you have blood available, let's not forget about blood. It's not to say that you can't consider some vasoactive agents as part of your resuscitation. Kind of depends on your protocols and thought process of the agency you work for, but certainly if you have blood and they're bleeding blood and you need to take their airway or provide sedation, let's get some blood on board, and then perhaps even consider some vasoactive agents as well to help bridge them through and survive that sedation and potential airway management. So always make sure that we are resuscitating, not just before, the resuscitate before we intubate, but resuscitate before we sedate. And if we try some of our frontline stuff and they're not getting better, let's always take a moment and make sure we're not missing something. And this is especially true in our trauma patients, really all of our patients, but definitely trauma. And so let's make sure we are ruling out things like obstructive etiologies like tension pneumothorax or cardiac tamponade. As you can see, I got some ultrasound images to show the pneumothorax on the left and tamponade on the right. Anytime I can sneak some ultrasound in there, I always will, because it's awesome and great and helps diagnose these different shock states. But anytime you're resuscitating and your frontline resuscitation isn't working, always tuck that in the back of your brain. Am I missing something? Is it one of these obstructive etiologies? Do I need to pop a lung? Do I need to get this patient for a centesis before we, and consider maybe holding off on sedation and intubation if necessary in those cases. All right, so that pretty much sums it up. So just a couple other extra links for some evidence to kind of support some of those things I was talking about, especially the utility of norepi and the comparison between that and epinephrine, are kind of what those two discuss. So in summary, to sum up a 20-minute video in about 10 seconds, any sick patient, even if it's not an airway case, before we apply procedural level sedation, let's take a look. Do they have an intact stress response? And if so, let's make sure we resuscitate them prior to sedation to prevent decompensation and death.